on his clinic experience and using Halcyon for treating breast cancer patients. Before I turn it over to Dr. Kennedy, I will give you a moment to review the Varian safety slide. And as a reminder, all products and features are not available in all markets. And Chris, take it away.
All right, thank you, Karen. So today I'm going to talk a little bit about our experience treating breast cancer at the University of Pennsylvania with Halcyon. Let's see, so here is my disclaimer slide. So at the bottom, you see the products and versions used. So we are currently treating with Halcyon version 1 and Eclipse 15.5. We are actually upgrading to Halcyon 2 and 15.6 next month, so I have some results on our evaluation of those products near the end of the talk. So a little bit about myself. I am a clinical photon physicist here at Penn. I was also co-lead physics investigator for our preclinical Halcyon treatment system evaluation. So a little about our clinic. We are a large academic center in Philadelphia, treating about 2,800 patient courses a year at our main center. We also treat an additional about 2,000 patient courses a year at our network locations. We have a fairly diverse patient population, really covering the spectrum of treatment sites, and we're somewhat unique in that we have a proton system in the same facility as our LINACs. We have the IBA Proteus Plus proton system. For the LINACs, we are strictly a Varian site, so we have 3 true beams, one with an HDMLC. We have 1 Clinac and 1 clinical Halcyon, and again, we are strictly Varian, so we have ARIA and Eclipse for treatment planning. So a little bit of a history of Halcyon at UPenn. So we were very lucky to have a prototype Halcyon installed at our main center in June of 2016, and then we spent the next year doing a preclinical evaluation, really to assess the clinical impact of Halcyon at Penn. Our diverse team included physicists, therapists, and physicians. So we looked at a number of clinical sites, including breast, and we really tried to compare the performance of our Halcyon to our C-arm LINAC plans as well. So a number of sub-scenarios evaluated shown here, and at the bottom you can see our timeline for installation of our clinical unit. So we removed our preclinical unit in summer of 2017, and after about a 4-week construction phase, we had our new Halcyon delivered on Saturday the 26th. We had it fully accepted by end of Labor Day weekend on September 5th, and then we were able to treat our first patient on September 11th. So about 2 weeks from loading dock to treating patients, to give you a sense of the efficiency you can get with Halcyon. So I wanted to just briefly talk about a quick overview and some background on the way that we treat patients at Penn before getting into our clinical experience with Halcyon. So this is the Halcyon unit shown here. So it has an enclosed bore geometry with a 1-meter diameter bore. So the patient protection you get from that bore geometry allows them to achieve very high gantry speeds, up to about 4 RPM, so about 4 times faster than TrueBeam. So all of the collimation is done by a jawless stacked and staggered MLC collimation system shown here. So you are restricted to a 28 by 28 cm field size, but that does allow for full over travel of all the MLC leaves. It has a single photon energy available at 6 flattening filter free, so there's no high energy or electrons available. And the couch is currently capable only of translation, so no rotations available on the couch. So here's some more details on the MLC. So again, it's a stacked and staggered MLC system. We have the top here bank. They call this the proximal bank, or closer to the source. And this is the distal leaf bank, which is closer to the patient. And they are offset by half of a leaf width. And with the current version of Halcyon 1.0, all of the field shaping is done by this distal leaf bank. So you can see the specs here. They're all 1 cm width leaves on Halcyon, but they are twice as fast as Millennium. You can see here in the cutaway, the cross-section, the Halcyon leaf is a little bigger than Millennium in HD, so it has better transmission characteristics, about 0.5% for Halcyon compared to about 1.5% for Millennium. And also the effect of the rounded leaf end, you can see it's a much larger radius of curvature for the Halcyon leaves, and this is a very minimal effect of the rounded leaf end, of the dosimetric leaf gap. and for about 0 for Halcyon compared to about 1.5 mm for the Millennium. So for imaging, so IGRT is actually required for all treatments on Halcyon. So there is a 43 by 43 MV imaging panel that covers the entire treatment field in place at all times. So MV imaging only on Halcyon 1.0, and you have a choice between MV-MB orthogonals or MV CBCT, but that imaging dose is actually included in the treatment plan. It's calculated at the planning stage, and you can evaluate the impact of the imaging dose at planning. So currently exclusions for Halcyon 1.0, KV imaging, that will be available for 2.0. Couch rotations, again, there's no non-coplanar fields or rotational IGRT corrections. And also really relevant to breast, there's no light field or ODI at the treatment isocenter. So all setup happens at a virtual isocenter at the entrance to the bore, sort of similar to a CT arrangement, and only orthogonal lasers are available for setup. So I wanted to cover just some basics of the way that we treat breast at UPenn for perspective here. So we immobilize with the Q-Fix angle board with arm shuttle and both arms extended. So we'll adjust the angle of the breastboard to level the sternum. For nodal treatments, we will use a vac lock to immobilize the arms and head. So at simulation, the physician will define the target volume, including the breast tissue, the superior, inferior extent of the field, as well as the lateral field entrance, and then the surgical scar. If it's present, then we'll define our setup isocenter with BBs anteriorly and both sides laterally, and then 2 additional marks along midline for straightening. So we do, for left-sided treatments, consider DIBH for our patients, and this is really due to, so the motivation is to improve the cardiac dose sparing due to displacement of the heart out of the radiation field with that deep breath. So we use the SDX system. It is a voluntary spirometry-based system that provides visual feedback through video goggles to the patient with an image such as this. That sort of guides the patient through a reproducible DIBH technique. And this requires a patient coaching session prior to simulation, and that's administered by the radiation therapist. For prone treatments, we use the Q-Fix Access prone breastboard with both arms extended. Again, we use a vac lock to immobilize the arms and head. So we'll center the affected breast in the board opening and align the sternum to center plate of the breastboard, and then sim typically with a 3 mm thickness. So after the scan for prone, we'll define our setup isocenter. So this is the isocenter at treatment where the therapist will try to achieve all the rotations and so on for the patient. So this we want on a location of stable anatomy. So we locate this soup to imp at about mid-breast, left to right at midline, and then antepost we have to find, again, that spot of stable anatomy. You can see it marked here, but it's often quite posterior. Additional tattoos, we have 2 posteriorly along midline for straightening, and we also have 2 lateral marks on both sides at the inferior straightening tattoos, so sort of here, and the motivation for that is because we have our ruler here on the side of the breastboard that we'll use to index the patient longitudinally, and then we index laterally using a ruler on the front of the breastboard. So for contouring, so we follow our TOG 1304 protocols for our breast treatment. So basically we treat sort of every breast as though it's IMRT. So the physician will contour target volumes, and then the dosimetrist will contour the relevant OARs. So this is a screenshot from the RTOG protocol. So we'll define our breast CTV based on the external markers defined at simulation by the physician. And we'll expand that by 7 mm to create a PTV, and then we will crop that back 5 mm from the skin and the chest wall to create our breast PTV eval that we use for assessment of plan quality. For our boost PTV eval, it's a similar procedure. We'll define our lumpectomy GTV and then expand that 1 cm to our clinical target volume, 7 mm from that to create our PTV, and then again we crop that 5 mm from the skin and chest wall to create our boost PTV eval. So for planning techniques at Penn, we do opposed tangents for whole breast almost exclusively. Occasionally we will add additional fields or maybe try VMAT for very challenging anatomy, but almost always oppose tangents. But we do modulate our tangent fields to achieve DVH objectives of the PTV eval. So when we do IMRT, it is an inverse planning with fluence editing. For non-IMRT, which is really the majority of the time for us, it's really a planner preference. Some like to use wedges, but field and field is by far the most common approach for us. For nodal treatments, we treat exclusively with single isocenter. And for the internal mammaries, we prefer to include them in partially wide tangents, but we will also sometimes do combined photon electrons for challenging anatomy. And for boost plans, we really prefer electrons, but we will do mini tangents and 3D conformal for challenging anatomy. And for post-mastectomy, we use 1 cm of superflat bolus every other day. So our treatment method is fairly standard, I think, sort of have clinical method where we'll align the tattoos from CT Sim, and then we'll shift to achieve the planned SSDs and the light field alignment. We will index our patients longitudinally using a side ruler on the breastboard, and we will give our expected treatment couch positions by the dosimetrist to the treating therapist. First day, we will do orthogonal KV imaging and portal imaging, and then we do weekly portal imaging thereafter. So I wanted to talk a little bit about our preclinical evaluation results and conclusions. So again, during our preclinical testing, we tested breast in a number of sub-scenarios, including intact, chest wall, nodal treatments, as well as pendulous and prone. So at least 3 patients per sub-scenario. So this was 19 total cases, and these were all previously treated patients at Penn. So we looked at field and field, irregular surface compensator, tangent field, IMRT, VMAT, and again a C-arm plan for comparison. So what we found is that really the biggest finding from the Halcyon 1.0 evaluation was that we really needed a new approach for simple fields, and this was due really to the modulation that we need to do due to the non-flat treatment beam, due to the FFF beam. So if you see here the Halcyon open field, if we just calculate a wide open field, it's fairly centrally peaked here. So what we need to do is some sort of modulation to flatten that beam, and we found the irregular surface compensator in Eclipse to be the best method to deal with that. So it's been in Eclipse for a while, so it uses the dose volume optimizer to generate an optimal fluence based on some desired penetration depth. And you can see the concept here for this irregular sort of breast-shaped surface. So if you define your 50% penetration depth, the optimizer will find the fluence necessary to deliver at that 50% depth the optimal fluence, and what it generates is this fluence that then sort of flattens the field at that desired depth. So the planning method is shown here. So you'll define your field aperture. You'll create your new irregular compensator in Eclipse, and that'll prompt you to define your penetration depth. So typically we go in the 40 to 50% range. A smaller separation would be corresponding to a lower penetration depth. And what that will do will generate a fluence that can be manually modified using the fluence editing tools in Eclipse. So for example, you could use the eraser tool to generate a heart block, or these various paintbrush tools to sort of manually manipulate the transmission factors to smooth out your hot or cold regions. Then once you have a fluence that you're happy with, you can use the skin flash tool to extend the fluence beyond the skin. And then ultimately that will create a sliding window MLC sequence for treatment delivery, sort of similar to a sliding window IMRT. So it's just some high-level preclinical planning observations that we had. So we were able to generate clinically acceptable plans with Halcyon 1.0 for all of the patients that we looked at, all 19 patients, and this is using, again, the irregular surface compensator and tangent field arrangement. We found that irregular surface compensation was really fairly straightforward. There's a bit of a learning curve for therapists or for dosimetrists that haven't used it before, but ultimately for a skilled dosimetrist, you have very comparable quality to IMRT and probably less planning time required than C-arm field and field planning. So regarding field and field planning, we found that for small fields for Halcyon 1, it was reasonable, but not really for whole breast fields. There's just too much modulation that needs to happen due to the central peaked FFF beam, and it requires up to maybe 10 to 15 segments per field to achieve reasonable homogeneity. So it requires a lot of planning effort. We did find nodal cases to be very challenging, and this is due to complications of matching the superclad fields with divergent field edges. So if you imagine where a single isocenter would have to be to treat the noble cases, it's quite a bit inferior to where you'd like your typical match line to be. So you have a lot of divergence at that match line that needs to be addressed. So breast cone down plans we did find were generally not problematic to achieve acceptable dose distributions for even if they were treated clinically with electrons, we were able to get good results with the cone down plans. So regarding dosimetry, again, so we normalized all of our plans to achieve 95% prescription coverage, 95% of the PTV. And because we're using that tangent field beam arrangement, we found sort of the predictable result that because Halcyon only has the 6FFF beam available, that it sometimes did have higher total doses compared to the C-arm that was able to use a mixed energy approach. So we did find sometimes with Halcyon that we were, based on our RTOG 1304 constraints, sort of going into the acceptable variation category, but still really in the clinically acceptable range. Now, you can certainly mitigate this with VMAT approach or more IMRT fields, but that may push some of your low dose into your OARs compared to that tangent beam arrangement. So regarding OAR doses, we really saw very generally comparable performance. So one notable exception is the lung V5. So if you look here at a dose distribution of Halcyon compared to TrueBeam, we do see some low dose sort of spilling out into the lung there. And this is really due to the inclusion of that MV imaging dose. So we're using CBCT here for imaging, and we see the CBCT dose reflected in our dose distribution, which pushes some of our low dose here in the DVHO. So again, this will go away with Halcyon 2.0 when KV imaging becomes available. So now moving on to our clinical experience at UPenn. So we treated our first patient in September 2017. We installed our clinical unit in a former Clinac IX vault that had an existing lap laser isocenter, and we found during our clinical testing that additional lap laser may be useful, particularly for prone breast, and I have some slides later on how we're going to use that, but we located the Halcyon such that the lap laser isocenter was about 80 cm behind and about 10 cm above the Halcyon setup isocenter at the front of the bore. So breast patient selection, again, so we're using Halcyon 1.0, so we do have some restrictions that we need to address. So first, field size less than 28 cm, and this is due to that single isocenter plan restriction for Halcyon 1. It is possible to treat with multiple isocenters, but that requires multiple imaging sessions and coming in and out of the bore, so it's not an optimal workflow. Anatomy appropriate for 6FFF only because we typically do treat with those tangent fields and 3D conformal technique. So some of the larger patients may not be appropriate for 6FFF. And currently we do this by test planning. We try to treat our patients on Halcyon, and if it's too hot, then we will move to the C-arm for that. So another issue for patient selection is collision avoidance. So typically, collision avoidance with the bore is assessed in Eclipse. So anything that's in the patient CT or the treatment couch can be assessed in Eclipse because the Halcyon bore is overlaid in the planning system, and you're able to see that you're not going to collide based on a given isocenter placement. The trick for breast, though, is that the contralateral elbow can sometimes be the point of collision, and it's not included in the CT scan because that would require us to scan up to the level of the brain, which is really suboptimal. So what we do is we make manual measurements. So relative to the couch, we'll measure the elbow position, and then also relative to patient midline, that contralateral elbow position, we'll give that information to the planner who can then come into Eclipse and use measuring tools to verify that there will be clearance for that elbow. And this is an example where we did actually have to move the isocenter a bit medial and a bit anterior to accommodate the elbow position. But what we found is that we've not had any trouble with this method. We've had no collision issues, and all of our patients have fit in the bore very nicely. So for IGRT, we are using the low-dose CBCT, and this is really one of my favorite things about Halcyon is the implementation of CBCT is very nice. So you're able to do it in the treatment position, so there's no table centering necessary. There's no need to check for collision with imaging arms. No need to extend or retract imaging arms. So the whole thing takes about 15 seconds. It's a 200-degree CBCT. And then what you have is this, in the IGRT workspace, the ability to overlay the beam path. So you're able to verify that you're blocking the heart or that you're including the IMN volumes, and you can overlay your planning structures and see that your alignment is very nice. So really nice implementation of CBCT on Halcyon. So clinical data collection, our therapists are collecting quite a bit of data to assess the efficiency that we're seeing with Halcyon. So they look at the time from the beginning of IGRT until the completion of treatment, so basically from when the cone beam starts to when the last treatment beam finishes. Total time in the treatment room, whether repeat imaging was necessary and why. Also a subjective assessment of treatment positioning quality based on the way the images look. And finally, whether that additional lap laser isocenter was useful to inform future installations of Halcyon. So here are our results currently for our breast treatment study. So we have treated 16 patients now to date, 15 supine and 1 prone, so that's over 340 treatment sessions. We found that lap laser to be useful for all cases, especially the overhead sagittal to assist with straightening. Re-imaging frequency, we're really happy to see that no re-imaging has been necessary, close to 97% of the time. So they're getting that set up right the first time, almost every time, with just those orthogonal lasers. Treatment positioning quality, they're finding in the good to great category well over 90% of the time, which was very nice to see. For our time to complete just the treatment from IGRT to end of treatment, we're seeing generally in the 3 to 4 minute range for an average. And total time in the treatment room, we're sort of within 1 standard deviation inside our 15-minute appointment window. So we're seeing very nice efficiency with Halcyon. So one thing I did want to mention is the skin dose. So I mentioned for post-mastectomy patients, we treat with every other day superflap bolus on the C-arm Linac. So for Halcyon, it's a bit problematic because with Halcyon, you really want to include all of your nodal fields in a single plan because that allows for a single imaging routine. But with Eclipse 15, you get to assign bolus at the plan level. So this means that the bolus has to be attached to all of your nodal fields as well. So there's some suboptimal workflows there. So we wanted to know if can we treat without bolus for these post-mastectomy patients. So we made measurements at 9 locations using the Landauer nanodot OSLD. So that's a 0.4 mm water equivalent depth, and we saw it's right about 70% of the prescription dose at the surface. So we really deem those results acceptable to treat without bolus for our post-mastectomy patients. So just a couple of very quick notes here. So we do find that our SDX breath hold solution shown here really fits in the bore without any issue at all. So it's really fits very nicely. And just to highlight some of the differences relative to institutional standards, so we are doing the irregular surface compensator on all our patients, and that does require IMRTQA for us, so that does a little bit more work for physics. And again, so we typically set up at the machine with the ODI and light field and so on. So setting up with daily imaging and lasers only is certainly a departure from our standards. And finally, no portal images. So no portal imaging on Halcyon. So the only imaging you have is from that CBCT daily. So moving on to some case studies that we've seen here at Penn. So first is a left side supine DIVH with a sort of Canadian fractionation for the tangents and a boost to the surgical site. So we send supine with a 10-degree breastboard angle, and we send under DIVH again to reduce the heart dose. So somewhat unique to Halcyon is that, again, that MV imaging dose is included in the treatment plan. So the first step in planning is to actually define the extent of your MV imaging. So for the initial tangent phase, we did a low-dose CBCT with a 20 cm field extent. And for that, we had the matching instructions were to align the chest wall and then verify alignment of the breast PTV. For the boost phase, we were very happy with the matching that happened in the initial phase, so we decided to go with orthogonal images for our boost phase, but we did consult with the therapist to make sure they were going to have the anatomy that they needed to see in those images. So we have a 26 cm extent, sup to inf, to include the clavicle, and then 20 cm laterally. And again, all of the imaging doses is included in that dose distribution in the DVH. So for planning, so this patient was sort of medium anatomy at 25 cm separation mid-tangent. So we were able to, just based on our standard institutional standards for field and isocenter placement, placed the isocenter. There was no collision issue. We planned with the irregular surface compensator with a 40% penetration depth, and then adjusted the fluence to achieve our standard PTV coverage and OAR sparing goals. We did actually use a heart block to block the heart, and made the decision to compromise just a little bit of PTV coverage here to block the heart. So our planning results, we met all planning objectives with our tangent plan. Breast PTV eval and global max dose were within the RTOG 1304 sort of ideal category there. And this, again, this DVH does include the imaging dose. For the boost planning, we used a mini tangent technique with opposed fields, and the M1C aperture defined with a 5 mm margin. And again, used a regular surface compensator. For this, we got a global max dose of close to 108, and we did meet all of our planning objectives with the exception of the total dose to the breast, and this is really just due to the size of the boost volume. It was quite big. So regarding the treatment deliveries, we averaged from the time from start of IGRT to end of completion of the treatment was a little over 5 minutes, so slightly longer than our average of 3 to 4 minutes, and this was due to including DIBH. We were generally able to fit, though, within our 15-minute time slot. Daily positioning, we found the lap laser really useful for all fractions. Reimaging, we found only necessary for 2 out of the total 21 treatments, and both times was due to the yaw, sort of the couch kick direction. We did find the CBCT to be very effective for setup, and here's a sample image here. We can see alignment of the heart, lung, and breast PTV as well. And we did note that there were no differences in skin reaction relative to our C-arm treatments. Okay, so case study 2 was a prone case. So this, again, it was a Canadian fractionation. Saw a mid-tangent separation of about 17 cm, and this is another observation from our preclinical testing, was that prone generally has the smaller separation, so really it works out very well with the 6X only beam for Halcyon. So for daily imaging, we chose low-dose CBCT for whole breast was 24 cm in length, and the boost was 13. So the planning, again, this was fairly straightforward because of the anatomy. So the planning, it was fairly easy to meet our planning objectives. So really the trick with prone is the setup. So we did see during our preclinical study that the setup isocenter, that point on the patient that has that stable anatomy, was often not achievable on Halcyon with our Q-Fix prone breast board because Halcyon requires less than 36 cm from your isocenter down to the tabletop, or the couch will collide with the bore. So this is one of our motivations for making sure we had this lap laser isocenter that, again, is about 80 cm behind and about 10 cm above the Halcyon. So for setup of our prone patients, for this patient actually did have fairly straightforward anatomy. She wasn't as big, so we were able to set her up either at Halcyon or the lap laser. But we set her up at the lap laser isocenter to have a little further, longer extent of the lasers, and then we were able to set her up then at the Halcyon isocenter as well. So our strategy, so in the case where that setup isocenter is not achievable on Halcyon, the strategy will be to perform our straightening and leveling at the lap laser isocenter, and then manually measure that vertical shift distance from the setup to the treatment isocenter, which is generally going to be sort of mid-breast, with a ruler, or we could maybe shift the couch, mark that location on the patient, and then we'll use that location to set up at the Halcyon setup isocenter. And prone treatments generally have no clearance issues at all with Halcyon at the treatment isocenter. So for the left-sided prone treatment delivery summary, so we have an average time from the start of IGRT to completion of about 3 minutes. So it's a very efficient treatment. So we are able to generally fit inside the 15-minute window, even though for this patient we did give ourselves a little bit more time because it was our first prone patient. So daily positioning, again, we found that lap laser very useful for all fractions. We did not need to re-image ever for this patient. She was set up the first time right every time by our therapy team. And we did find the CBCT effective for tangent and boost setup, and you can see a sample here where we've got the lung heart aligned very well, and then the breast PTV volume as well. So again, no difference noted relative to C-arm treatments. So our case study 3 is a supine treatment that included nodal fields. So in this case, this was a case that had dose prescribed to really all the nodal fields, including internal mammary, supraclav, and the axillary level 1, 2, and 3. And the total field length drawn by the physician was about 27 cm from top of supraclav down to the tangent. So we tried to plan this with Halcyon. So the planning approach here is a single isocenter, and I mentioned earlier sort of the challenge with these nodal cases is managing this divergence up here. So the isocenter, the single isocenter for Halcyon, is sort of more toward the middle of the breast, and you can see that due to the divergence of these fields, you have to contend with the overlap of the hot and cold triangles due to the divergence. So in this case, the planner elected to rotate the collimator 2.3 degrees to match the medial field divergence, and then use a field-and-field technique to smooth the dose out sort of in the this hot region using segments, particularly a segment such as this one that sort of blocks that hot triangle there. And so the results shown here, so the 3D dose max of almost 119% in divergence overlap at the match line was a slight violation of our RTOG protocols, but otherwise this was an acceptable treatment plan. But this sort of illustrates the challenges with the single isocenter technique. So that's the segue into our Halcyon 2.0 evaluation. So I just wanted to sort of reiterate the challenging scenarios with Halcyon 1.0 and how we might mitigate them. So again, targets larger than 28 cm. You can use a multiple isocenter technique, but again, that involves multiple treatment plans, multiple imaging sessions. So it's not an optimal workflow. You have the non-flat beam, which can be mitigated by irregular surface compensation, but this does require fluence editing for the tangents. With the 1 cm leaf resolution, so I mean you can rotate the collimator to find optimal conformality. So the 6 MVV beam only. Again, you can add additional IMRT beams or a VMAT approach, or again, prone is another possible way to mitigate that. And finally, the MV imaging dose, and just a reminder that the MV imaging dose is included in the treatment plan. So for the Halcyon 2.0 new features, so we did test an early release of Halcyon 2 and Eclipse 15.6 as part of our research agreement with Varian. So first, dynamic beam flattening. So that allows replication of the flattened beam workflows. For targets larger than 20 cm, there's a multiple isocenter technique to potentially simplify the breast nodal field planning. The proximal leaf bank will modulate the beam with Halcyon 2, so that'll allow for better MLC resolution. There's a machine change feature from Halcyon to non-Halcyon, and one we're really looking forward to is the KV imaging to improve imaging dose and quality. This will be CBCT only because of the offset detector arrangement they'll have that will give us a larger CBCT field of view. So just to run through some of these new features. So first, dynamic beam flattening. So this will work by having the proximal leaf layer, that's the one closer to the source, go through a dynamic beam sequence to flatten the FFF beam profile. And then the distal MLC leaf layer defines the treatment aperture. So the procedure will be to add your flattening sequence in Eclipse. And then you can basically replicate your standard field and field treatment workflows at that point and weight the beams using the weighting tools in Eclipse. So you're really able to replicate the workflows that many planners are already comfortable with. So, of course, the 0.5 resolution of the MLC. So you have independent movement of both MLC layers to shape the treatment fields, and that's not available for dynamically flattened beams because, again, that proximal layer is busy flattening the beam for you. So you have an effective 5 mm resolution for non-flattened beams that give you better conformity to the irregular shapes. So next, the multiple isocenter support. So this will allow a maximum of 2 treatment isocenters per plan with a maximum of 8 cm longitudinal separation. So that will extend the maximum treatment field length to 36 cm, where it was 28 cm. But very nice feature, they have an auto feathering between isocenters for IMRT and VMAT, which will sort of smooth the dose in between the 2 isocenters. So the procedure, there's 2 different methods to define a multiple isocenter plan. So they are the duplicate isocenter groups, which is shown here. So basically this will allow you to create an initial isocenter and then create a new one up to 8 cm away longitudinally. And the second they call the multiple isocenter setup, shown here, where you have an initial isocenter, and then the multi-isocenter will create two new isocenters at plus or minus 4 cm from the original ISO, and then your imaging will remain at that original location. So we looked at a case study. So this was a patient where we had prescribed to all of the nodal volumes again, but in this case the total treatment field length was drawn as 31.5 cm by the physician. So we did elect to treat on TrueBeam due to the field length. So we use this as a test case to really look at the new workflows in Eclipse 15.6 and Halcyon to test to see if we would be able to treat this patient now with the next version. So we looked at several workflows. So again, we treat typically with 3D conformal techniques rather than IMRT. So we wanted to make sure we had a 3D method approved. So we tried various approaches, and we basically settled on a technique whereby we sort of treat them the tangent fields and then the superclav and PAB separately, and then combine them later. So the first plan will be at our tangent isocenter. In this case, we want to place our ISO such that we're getting full coverage of our PTV, with being as close as possible to the match line isocenter, but not more than 8 cm. And then we'll just define our tangent fields and go through a field-in-field planning process with dynamically flattened beams, just as we would. So basically replicating our existing workflow. We are including the internal mammary nodes in our partially wide tangents here. The next step is to create a new plan at the superclav fields independently. So we'll define an anterior and a posterior theme, sort of a superclav and PAB field arrangement, with the posterior as a dynamically flattened beam. But the anterior field, we're going to rotate the collimator 90 degrees, and that's going to give us the MLCs in the sup to imp direction for better modulation. And then we'll be able to edit our fluence to achieve whatever desired homogeneity. So at this point, we'll adjust our field weighting to get our desired coverage. And in the next step, we're going to go and back to the tangent field plan. We're going to duplicate isocenter groups to create a new isocenter at our desired match line. Then we're going to insert those superclav fields that we just created separately. And that allows us to evaluate the combined dose distribution. And then we'll have the superclav anterior fluence to really smooth the dose out at the match line and address some of the divergence issues. So with this technique, we were able to get a clinically acceptable plan, sort of close to 115% at the match line. And our breast PT val, again, was clinically acceptable, and planning time for this was close to an hour, and this is for a very skilled planner. So the dose distribution is shown here, so you can see slightly smaller effect of that divergence from the field edges, and ultimately as a nice acceptable plan. But I think with Halcyon 2.0, really the power of the new system is really in this auto feathering feature for IMRT. So we wanted to look and see what type of plan quality we could see, sort of leveraging these features. So our field arrangement in this case is going to be the same as it was in the previous method with 3D, but now we're going to add additional tangent fields to the match line isocenter, so more of a typical single isocenter breast arrangement that will be allowed to feather with the inferior isocenter tangent. So that arrangement is shown here. We have our first ISO, which is going to be mid-breast with our tangents. The second ISO is our superclav match line with our superclav and PAB, and then a second set of identical tangents here that will feather to create a nice smooth dose distribution. So we optimized the IMRT with auto feathering enabled, and this is in the dose calculation options. You can turn it on. And at that point, we do this very sort of standard IMRT, really nothing fancy here. We've got a very highly weighted objective on the body, sort of nominal objectives on all of the PTVs and the lung and heart, so there's no additional feature or structures necessary to shape the dose or anything like that, so fairly straightforward optimization. And what we get, and this is the unedited fluence after our optimization to give you a sense of how this auto feathering is working. You can see here, this is the isocenter sort of in the breast tangent. So we've got this isocenter fluence is really dosing all the inferior parts of the breast, and then sort of a decreasing fluence up here toward mid-tangent. Is actually contributing some to the nodal volumes, including the superclav, and then the medial field here at the match line isocenter is sort of filling in the rest in a sort of a smooth gradient in between the two. And you see a similar arrangement here for the lateral isocenters. And then finally, we have the supraclav and the PAB fields that also are sort of feathered and contributing nicely to the IMNs as well. So this is the DVH that we get from that just initial optimization. This is just one run of that sort of first try. And you can see it's actually a really nice plan. First try, it's a fairly conformal dose distribution here to our PTV eval. The lung dose is actually quite a bit less than our 3D technique. It's not quite a fair one-to-one comparison, as we're not really treating quite as much anatomy as those physician-defined tangents. But still, it's a very nice plan, actually a little bit better on the heart dose. So this is a really nice starting point to get a very nice IMRT plan. And I don't have a slide for it, but I also looked at some of our larger patients and tried to do sort of a 5-field IMRT approach, and really got a really very nice result first try, very beautifully sort of conformal and homogeneous plan on the first try. So IMRT is clearly very well implemented in Eclipse 15.6. So in conclusion, Halcyon offers really treatment options for all the breast cases that we evaluated in preclinical testing, and this again was the opposed tangent field, irregular surface compensated plans. We were able to satisfy our RTOG 1304 constraints for all of our preclinical test patients. Simplified treatment workflows, reduced delivery times, and really a very nice implementation of cone beam CT for breast. But some of the considerations, again, we have the maximum field extent of 28 cm, so that will be mitigated in Halcyon 2.0 with the multiple isocenter support. The 6 MV beam for tangent field geometries can sometimes result in some high doses, but you can mitigate it with additional beam arrangements or VMAT, or, as I mentioned, prone. Prone is actually a really a nice way to treat on Halcyon. So you have the 1 cm MLC resolution. So the effective resolution will be 5 mm in Halcyon 2.0. You have the non-flat beam, so that can again be modulated with IMRT or a regular surface compensator, and of course with the dynamically flattened feature in Halcyon 2.0. And finally, the MV imaging dose, and again KV imaging will be available in Halcyon 2.0. So I wanted to thank our Halcyon evaluation team at Penn, and I guess answer your questions.